Okay, so let's cook. Obviously, acute renal, you found it? Acute renal injury and chronic kidney disease are very, 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 very different. One of the things with acute kidney injury is you had to know the types, and if you turn in your packet to AKI, somewhere in the midst of it all, there's two, yeah, you sit there because the seat is in the light, of course. But yeah, if you turn to AKI in your old renal packet, for those of you who've been here before, Catherine, your old one. And then if you look at the other side, there's 2 pages. Then, because it's a big deal on this test too, behind it is who needs dialysis. Okay? So you should be okay as long as you got the little lady. We're going to start with the little lady. Yeah, acute kidney injury, start with her. And let me remind you, we had 3 types. We had pre-renal, we had intra-renal, and of course we had post-renal kidney injury, if you'll remember. Pre-renal, intra-renal, post-renal. And I gave you a trick. I told you with pre-renal, this was going to be about switch the letters up, perfusion, or blood flow to the kidneys. With pre-renal, so you just write your pre-renal down. It's the same exact thing. Don't get the new one. Yeah, they're the same. They're so much the same. Rifle and that. Rifles on the back of it. Yeah.
Is that the one you want me writing on?
It doesn't matter. But we're on the little lady. Okay, so your pre-renal, you have perfusion, put in parentheses, low blood pressure. If you have a low blood pressure, you obviously have no perfusion to your kidneys. Oh, that's lovely. Whose boyfriend's calling? Is that your woman? Don't kill yourself because I ain't got no insurance. All right. So the pre-renal, low blood pressure, no perfusion, always with shock, always with hemorrhage. So if a patient is in shock or they're hemorrhaging, they're going to have what we call pre-renal kidney failure. And this is something you have to worry about with, your surgical patients. They're in surgery, they're bleeding and bleeding and bleeding, and here we go. You also have to worry about this with burn patients, that kind of crap. All right, so that's cool. Intra-renal kidney failure, I told you to remember the I is injury. The I stands for injury. This is where you actually poisoned the kidneys. Maybe you used, and yes, you do have to know this, maybe the doctor ordered aminoglycosides, which is vancomycin or gentamicin or tobramycin. Most of them end in mycin, so it's kind of nice. But don't be fooled. Erythromycin is not an aminoglycoside. Vancomycin, gentamicin, tobramycin, yes. Those are aminoglycosides. Those are poisonous to the kidney. If a patient has some kidney problems, you're going to kill the rest of their kidney function. Also, don't forget with this intrarenal kidney injury, you could be talking contrast dyes. You could be talking about metformin with contrast dyes. You could be talking about giving a patient maybe with some mild kidney insufficiency or failure, mild, Maybe you were crazy and you gave that patient NSAIDs like ibuprofen, Motrin, Advil, Aleve. That's going to injure the kidney. So those are going to injure the kidney. The toxins, the poison, the actual damage to the kidney, that's what you're going to see. You're going to see intrarenal kidney injury. Okay? And then, of course, there's the post-renal. Now, that's the easiest one of all because you just have to remember post and O for obstruction. You literally have obstructed the kidney. So it has nothing to do with perfusion. It has nothing to do with the ability to make urine. The urine can't get out. That's called kidney stones, or as you know it, renal calculi, or what the hell they give you guys? Yeah, urolithiasis. It's so fancy. So urolithiasis, okay, kidney stones. It's also cancer. Tumors will prevent urine from coming out. One of the number one reasons why urine can't get out is BPH, or benign prostatic hypertrophy, and enlarged prostate. It's going to totally block urine from coming out. So that kind of sucks. All right. So your acute kidney injury patient, if you'll remember, if you look at your sheet, your little handout, you'll see the 3 phases. They have an oliguric phase. And don't forget what we taught you before. The only way to get rid of potassium is to pee. So if your patient has oliguria, are they peeing? So what's their K? Yeah, their K is high. And then the next phase is diuretic. And as you know, with that phase, they are peeing a lot. And now they have a low potassium. Okay, so some of this stuff, it's a nice review for you. Okay, so if you think about the patient with, the chronic or the acute kidney injury, the one thing I did want to make sure you guys remembered for that is that the patient's kidney function can take about a year for them to completely recover. At the bottom, it probably says something a little bit like that. Takes a whole year for the kidney to truly recover, for the patient to truly recover. If it hasn't happened in 3 months with regards to making urine, which is different from the healing process, takes about a year to heal up, but if you haven't made urine within 3 months, because this is reversible, right? So if you haven't made urine, then now we say that you're in end-stage renal failure, and that patient will continue to need dialysis. So the entire healing process for the patient to feel better and all that good stuff is a year, but after 3 months, it's like, okay, she may be in end-stage renal failure. One thing I want to tell you, too, is the onset of acute kidney injury can take hours. It's really quick for some people, especially if you blew their kidneys out the water with aminoglycosides or contrast dyes, metformin with contrast dyes. We always monitor BUN and creatinine. And nowadays, we're so strict, we pretty much monitor that before we order anything with contrast dyes. We're just really strict anymore. We're not trying to kill anybody's kidneys. So the BUN and creatinine, the creatinine will be more sensitive for acute kidney injury. The creatinine is more sensitive for acute kidney injury. The BUN is influenced by hydration status. The BUN is easily influenced by hydration status. So creatinine tends to be a little bit more reliable. The best lab for all kidney function is a 24-hour urine for creatinine clearance. The best test for kidney function is a 24-hour urine for creatinine clearance. It's the best indicator we have of kidney function. And yes, you had to know what that is. And the normal is 85 to 135. To 135. So like we said, acute kidney injury begins with some type of insult, whether it was no blood flow, low blood pressure, no perfusion, which is all pre-renal, or it was injury with a chemical or toxin or poison, and we do worry about with children poisons, or it was blockage because you have this tumor. More importantly, you have an enlarged prostate that's blocking urine flow, or you have kidney stone. All three are types of acute kidney injury, all three of them. And it starts with one of those assaults to the kidney. And then, of course, it's recoverable, like it's reversible. You know that already. Takes hours. The max days. I mean, maybe, maybe in the case of preeclampsia, which is typically what I see, it took a couple days, but they still have kidney failure very fast. And, they recover kind of fast. So if you look at the rifle page, behind it, behind it. I should have been behind it. You don't have one behind it? You're not even where we were. Where's your acute kidney? You don't get it. Don't start with me today, brother. There it is, behind it. If you look at rifle and you go and you look at the very first entry, what lab do you notice? Yeah, highlighted, of course, right? So that's more important than anything, that you just kind of always associate creatinine. And then as you go down, at the very end, it says, complete loss of kidney function more than 3 months is called what? Yeah, kind of got to know that. End-stage renal disease. Okay, so that's easy. Now, the chronic kidney disease patient, you know very well with this patient that we're going to have a lot of no-nos. Some no-nos I've gone over already. We said no aminoglycosides, no NSAIDs. That's the first page of your packet that you guys have, the funky looking lady. So once we start getting a kidney disease at all, this is chronic kidney disease. Once we start to get to this point, we're saying no. We're trying to protect her kidneys as long as we can. And by the way, she can go like that for 20, 30 years. My own mama has been diagnosed with kidney disease, 30 years ago. She's doing fine. Okay. Now, but we're strict, right? We have some things we know we shouldn't do. And so we don't do NSAIDs. We don't do aminoglycosides. We don't do magnesium products like milk of magnesia, Maalox, Mylanta. We don't do magnesiums. We would never, ever, ever dream of doing contrast dyes without checking a BUN and creatinine first. If she was a diabetic, we wouldn't be having metformin and a contrast dye together. We would have to hold it how long? 48 hours before and 48 hours after. Okay, so you know that. We would control the blood pressure. What would you like to use to control the blood pressure with a kidney failure patient? What's the best drug? Works on everything, actually. ACE inhibitors, big letters, capital letters, put it on your paper. ACE inhibitors are the best medication to control for kidney issues, blood pressure issues. It's going to protect the kidneys. It's actually going to protect the kidneys. Remember what the causes are? The causes of chronic kidney disease, just reminder, is uncontrolled high blood pressure, so uncontrolled hypertension, diabetes, lupus, those are the three big ones. And then to a lesser extent, polycystic kidneys, polycystic kidney disease, cysts all over the kidneys, polycystic kidney disease. Okay? Of course, the best thing you could do for any patient with any failure, whether it's kidney failure, liver failure, heart failure, you don't give a shit. The best thing you can do for any of those failure patients is have them get a scale, because daily weights are the number one indicator of fluid imbalance. And 2.2 pounds equals what? How much fluid? 1 liter. 2.2 pounds equals 1 liter of fluid on the human body. So we tell the patient to call us if they gained what? 3 pounds in a day, 5 pounds in a week. Very good. You guys are jamming on this. Okay. Diet. Let's do a diet. The diet is the most restrictive for this patient. This diet for this patient is going to be low potassium, low sodium. And let's think about those for a hot minute. Low potassium, low sodium. What foods are rich in potassium? Everybody always says bananas, but I want to, there you go, you sound better. Tomatoes, potatoes, both of them. Potato, potassium, potato, potassium. Yeah, you can't forget that. And that's how my students remember it on the test. They're like, oh yeah, potato, potassium, it's in the word. So that's the highest potassium-containing food, potatoes. P for potatoes, P for prune juice. Tomatoes, you already got that. You're jamming on that. Fresh fruits, especially citrus fruits, right? So orange juice, all that good stuff, lemons, whatever. What's low in potassium? What juices are low? Apple, yep. And one more. Cranberry, yep. Don't forget those. You gotta know that stuff. Okay, so cranberry juice, apple juice are low. Safe juices for the patient. What vegetable is high in sodium? Naturally occurring sodium? I heard it over here. I thought spinach. Spinach, yep. Spinach is high in sodium, normally, just naturally occurring. Not as bad as spinach, but celery is good. But spinach is number one with tomatoes. And then celery, it's probably moderate, not as high as those two. Okay, but whatever, you got the gist of things. Hidden salt is in bread. Hidden salt is in bread. Obviously fast food, frozen foods, and canned foods. Your soups are ridiculous. The other part of the diet includes decreased protein. What would be the exception for decreasing the protein. Who would I not decrease the protein in? Dialysis patients, yeah. If you're getting dialysis, you need high protein. If you don't get dialysis and you're just trying to preserve your kidney function, you need low protein. And don't forget, protein is in all meats. So that's a big deal. Protein is in all meats. Okay, so far you got your low potassium, your low sodium, your low protein, and phosphorus. Phosphorus is high in what? What foods? Dairy, peas, nuts, pop, beans. Those really short words that have 4 letters in them. Pops, beans, nuts, peas, short words. Beans, nuts, pop, and dairy. Yep, dairy. Okay, you kind of want to know that. Now, you do need to know for the aging patient that the glomerular filtration rate naturally goes down, so they hold on to their medications longer. You want to remember that. Due to the normal processing of aging, their glomerular filtration rate does go down, and they lose the number of nephrons as well. So GFR goes down with aging. Number of nephrons decreases with aging. The patient that has this issue, the 65 and older patient that has this issue, because that's what we call geriatric patients, their medications are not going to clear as fast. There's a risk of toxicity, as you probably know. There's a big risk of toxicity. We're dealing with that. What's creatinine clearance normal again? 85 to 135. Good enough for me. Okay. Let me see if I have anything else exciting. Told you daily weights. Yes. Now, for end-stage renal disease, I want you just simply to remember what we already said earlier in the semester, which was for the patient with an AV fistula, and there's a page with the lady sitting down in the chair in the first couple pages, if you're going too far. Yep, like the next page. If you look at the bottom, there's a nice little box there, and the box is just telling you and reminding you what not to do. But let me just make sure you remember that we have to always assess for a bruit with the bell of the stethoscope. So we hear a bruit with the bell of the stethoscope, and we feel a thrill. And I taught you guys, if the thrill is gone, it's an emergency. Because essentially the patient may have clotted off. So every morning, you should be teaching patients to feel a thrill. And if the thrill is gone, it's an emergency. They may have clotted off. Does that make sense? So hear a bruit, feel a thrill. Okay. Now, no blood pressures. You already know this. No blood pressures, no needle sticks. And here's why. You basically have taken the artery and the vein and created a nice little tunnel or fistula. And so you don't have the ability to do the things that normally you would do with that arm anymore. You can't carry a heavy purse. You can't, wear really tight clothing. I mean, it's just really interesting what you can't do. And let's remember why. If I poke this patient with the needle and I get this thing infected, then it's really going to impair the ability to do dialysis. And dialysis has to be done every other day. Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, period. So if I go and I put a needle in the patient, I'm going to have a possibility of introducing bacteria to an area that the worst thing that could happen is that they get an infection. But then, if you remember just common sense, the minute you poke them with the needle, platelets gathered to clot that area off, and now you have platelets in that arm, and the potential of clotting off that AV fistula or whatever graft is real. Okay, so you don't want to do stupid stuff. And then you also don't want to put in tourniquets and things because you're going to cause pooling of the blood. Wherever blood pools, because you squeeze the arm, wherever blood pools can clot. Okay, so you know that, but still. Okay, so that's that. Transplants. You have somewhere in your travels, probably towards the last page. I thought it was the last page. Yeah, you should have something on transplants. Second to last page, something. Okay. I thought it was, yeah, near the last. You just turned away from it. I watched you look at it. Yeah, there you go, baby. It says transplant. All right, so kidney transplant. This patient, I just want you to know, or remember, that the kidney is put in the pelvis, in the abdomen, pelvis. If you look at the picture, it kind of shows you that. It shows the rejection of it popping out of there. Don't think they put it in your back. We do not remove your kidney either. So we just leave your little pissy kidneys in there. They're not doing much, but we don't remove them unless there's some reason. So we're going to make sure that you put the kidney in the pelvis. The other issue is because this patient is on immunosuppression drugs to prevent rejection of the kidney, then we have to do everything we can to prevent infection in this patient. So we use extreme aseptic technique, and make sure you quote me on the fact that we remove the Foley very, very quickly. Because the patient comes out of the OR with the Foley. So we remove the catheter as soon as humanly possible. UTIs are directly related to catheters and how long they stay in. So in this patient, we're trying to get it out real fast. Also, just something to know, if the patient's kidney doesn't work, which happened to my student, she had 2 kidney transplants. Coming out of the OR, she didn't make pee, so it didn't work immediately, which is pretty fast. And it says hyperacute within the first 48 hours. Then the patient just is going to need dialysis. Keep in mind that with dialysis, we break the rules a little bit, and we'll tell you just one rule we will break. If I'm doing dialysis, then I could use vancomycin because I'm going to take it off the body. Agree? So I break the rule a little bit. All right. Also for dialysis, I thought might better review with you what medications to hold. And so if you go back to that little lady sitting down, you're done with renal transplant. You don't have much on that. But if you go back to that lady sitting down in that chair, I want you to put what medications to hold just in case you got to be revisited by that little torture there. Who can tell me a medication to hold? What'd you say, hon? Folic acid? All B vitamins is a better way to say that. B vitamins, all B vitamins, and another way to say that is multivitamins. So for dialysis, you're going to hold any multivitamin and definitely B vitamins because B vitamins are water soluble. And we're taking water off the body. So if we gave you a vitamin this morning with your meds, and then we put you on dialysis, we just pulled it right back off of you. So no multivitamin or B vitamins before dialysis, and folic acid is B9. You should know that. Okay. What else should we hold before dialysis? Blood pressure medicines. You better believe it. Because what are we removing when we do dialysis? Volume of fluid. What controls your blood pressure? Volume of fluid. So we're already making your blood pressure low the minute we put you on dialysis. then you're on 3 blood pressure meds before you went, and I was dingy enough to give them to you, hope not, but if I was, you're going to bottom the patient completely out. Like, seriously, you're going to have a problem on your hands. Okay, so blood pressure medicines, and don't forget, they could be ACEs, it could be calcium channel blockers, it could be beta blockers, so Prils and OLLs and Depines. Calcium channel blockers are Depines. Okay, so what else are we holding? Diuretics. Might want to hold those a little bit till we get done with dialysis because they do the same thing. They remove volume of fluid, and it's just redundant, really. You know, you don't want to go too crazy. There's another one that we hold because a patient could bleed. Aspirin. We're using heparin. As you may or may not know, we use heparin in dialysis, hemodialysis. We hang a bag and everything. It's part of the machinery. So we use heparin, so we don't need to have you taking a baby aspirin that morning, because it's probably not really important that you take something that's going to make you bleed more. Anything else we would hold? Antibiotics is good, because most of them are water soluble. That's what I've been waiting on. Digoxin. We would hold digoxin because digoxin is, you guys remember my armpits here. When potassium is low, remember what I do, digoxin is high. And when we take a patient and put them on dialysis, aren't we taking off a lot of potassium? So when the potassium is low, digoxin is high. Okay, so you got like a little select all there going on what meds to hold before you go to dialysis.